Well, good evening. We'd like to welcome you to our evening's presentation on live ICL surgery with a little bit of information about the stunning technology that is the Vision ICL. We are going to go through a bit of a PowerPoint presentation tonight with myself also introducing our guest lecturer, Dr. Greg Parkhurst, who's widely experienced in ICL surgery and the technology behind this marvel of vision correction surgery. So first of all, welcome. We really appreciate the fact that you're here, and we hope that this is in fact just a good event for you. You'll also have an opportunity to ask questions live, and as we answer these questions for you, please feel free, pipe up. This is very much an interactive medium. We live in an amazing age with the internet and the technology that this gives us to bring such events to you live. We have this posted on our website as well as Google Hangouts, so we really do appreciate your taking the time to be with us. So let's go ahead and start with what the vision correction surgery is. We do have a PowerPoint presentation here, and I want to make sure that that is actually live. We are live with the PowerPoint?
Yeah.
Okay, very good. We are coming to you, of course, from Salt Lake City, and here we go. So, when you think of modern refractive surgery, everybody automatically thinks of laser. And if you're old enough and part of my generation, you remember what lasers meant back in the days of James Bond and Sean Connery. Thankfully, our lasers today don't have anything to do with this type of procedure that Sean Connery was about to undergo himself. Lasers are actually the most commonly performed procedure in the world today. LASIK is that procedure that is done most often. And there are actually multiple platforms, multiple laser machines that can be used for this. Modern LASIK is truly an excellent procedure that has treated millions of patients worldwide. And our modern lasers do provide such stunning visual outcomes for nearsightedness, farsightedness, and even astigmatism that the procedures continue to grow worldwide today. Now, as far as the evolution of vision correction, if you go back a few thousand years, the ancient Chinese were using water bags placed on the eyes during the person's sleep to flatten the cornea and thereby treat their nearsightedness, their myopia. In the 8th century, it was discovered how to turn sand into glass, and this led to convex-shaped glass stones, which were used as magnifiers, and they called these reading stones back then. In 1286, the first eyeglasses to correct farsightedness began to appear simultaneously in Italy and China, and the term eyeglasses was actually something developed in 1306. In the 1400s, lenses for nearsightedness or myopia appeared, and of course in 1775, Ben Franklin himself invented the bifocal. Well, we know that Leonardo da Vinci sketched the idea for contact lenses, but the first ones actually were manufactured in Germany in 1887, over 300 years after da Vinci's conceptualization of the idea. Now, correcting vision is very significant. Eyeglasses, in fact, were thought to be one of the most important inventions of the past 2,000 years, as described in that article by Newsweek. Now, the evolution of refractive surgery, the patient's ability to get out of eyeglasses and contact lenses, was actually conceived of in the late 1800s, but in 1930, the first corrective eye surgery was done on Japanese pilots. These pilots, in fact, had radial cuts that were placed in the cornea to correct their nearsightedness. In the 1960s, Dr. Barraquer, a world-famous pioneer, developed procedures of corneal freezing and excision of tissues to correct the patient's vision. In the 70s and 80s, Dr. Fyodorov in Russia rediscovered and popularized placing incisions on the outer surface of the cornea to treat the patient's prescription. In the early 1980s, 1983, Dr. Stephen Trokel performed the first corrective eye surgery in Germany using a laser. Now, it really evolved at light speed from the 1980s on. Everything from incisions in tissue to actually excising tissue, removing tissue itself, and now to ablating that tissue in a very, very precise way with beams of light in a laser form. These are the PRK, LASIK, LASIK, and so forth. So truly, after 1,300 years, we've finally entered the age of laser vision correction surgery. and patients have learned that they can expect excellent visual results from their eye surgery. So the question becomes, is laser for everybody? Unfortunately, there are limitations to laser technology, and sometimes we'll encounter complications. In fact, a good deal of our time as refractive specialists is spent in our centers, in our eye clinics, and in our institutions trying to sort out those patients who unfortunately will be too risky to have a laser procedure done. Well, why even consider corrective eye surgery? You know, glasses and contacts, unfortunately, they do limit your activities, whether it be surfing, scuba, hunting, fishing, and so forth. You lose your glasses, or you lose a contact lens. You'll step on them, you'll sit on them, run over them, flush them, and so forth. There's no end to the ways in which you can lose this appliance, which helps you see better. Plus the fact that you have to spend so much time to maintain them and keep them clean, and the fact too that you have to update them. You have to keep spending more money to stay current with your prescription. As far as non-LASIK surgeries, what we find in our center here in Utah is that about 20% of our patients who show up don't even qualify to have LASIK. And we find some patients too that don't even want to consider LASIK or PRK due to whatever personal concerns they might have. They might have a phobia about having a laser come close to the surface of their eye, concerns about the irreversibility of the procedure, and so forth. Some surgeons don't even offer LASIK, but are more comfortable with other procedures. You know, in the old days, when a patient like this would show up, we would advise them to wait until something better arrived. And some surgeons, unfortunately, would really push the envelope, though, and go ahead and treat patients with a higher risk. And what we saw is that some patients would actually develop complications from their refractive surgery. Well, again, in the old days, cataract surgeries, very different here, were being done in greater and greater numbers with better and better outcomes, where cataract surgery just involves removing the clouded lens from the patient's eye and replacing it with an artificial lens implant. Artificial lens implants, as we saw during the time of cataract surgical advances, were actually giving patients really remarkable visual results. And this is just an image of one of these commonly implanted lenses that would be placed in the patient's eye after the cataract surgery. So the question then became, what if you could simply insert a lens into a normal eye in need of a prescription? Would this correct a patient's vision, and at the same time, you'd be able to avoid the step of removing that patient's cataract? Ideally, if the patient was young and healthy, they wouldn't need a cataract operation. So what if you could take one of these lenses and implant it into their eye? Well, let me see here. My beeper is not, or my clicker is not quite working for me here. You could therefore take care of these young, healthy patients. And what if you could actually come up with a material that was so biocompatible, that was so easily accepted by the body, by the immune system, that it wouldn't have any inflammation or any rejection, no pain? And what if you could take this material and then implant it into the human eye with the idea of correcting the patient's vision? Well, in 1993, the exact material was developed that I've described. It is indeed polymer, which is a very, very soft material, extremely compatible inside the body. And this had actually been developed for lens implantation by one of the Russian surgeons, Dr. Fyodorov, as well. He made a lens that was very, very thin that could, in fact, be implanted behind the patient's iris simply to correct the vision. So the first patients received this implant, known as a phakic IOL, in 1993. Subsequent designs became known as the implantable polymer lens that we're going to use today, the ICL or the Vision. So enter the modern era. Now we have the ICL. This is an image of what that looks like. It is a phakic IOL that gives patients a lens-based option, and no laser treatment is therefore required, and their entire prescription is taken care of by this little lens implant here. The spectacular visual results, even in patients who aren't good candidates for other surgical procedures, are really what sets this procedure apart. You can take a patient who's not a good candidate for LASIK or PRK and give them not just good or acceptable vision, but truly stunning vision. Now, in 1997, the US FDA clinical trial started. In 1998, the first ICL was implanted when I was in my Phoenix practice in Arizona. There were 526 patients implanted with the ICL under the study. Our Arizona practice had the highest number of any patients in that study. And then in 2005, the US FDA finally did release the ICL for patient use. I have done more ICLs than any surgeon in the US myself, so I'm very much experienced with this. I also help train and certify other surgeons, and I've lectured and demonstrated the actual surgery itself throughout the world. We are very proud to have a training center for national and international surgeons wanting to refine their techniques as well. Now, I'm also going to introduce now Dr. Greg Parkhurst. Dr. Parkhurst has a lot of experience with ICLs, as I mentioned earlier. Dr. Parkhurst is the former chief refractive surgeon in what was the highest volume ICL center in the military. He also teaches other surgeons on ICL surgery and has been awarded for his best clinical research by the American Association of Ophthalmology, Academy of Ophthalmology, and the American Society of Cataract and Refractive Surgery for his work in this field. He is also the youngest founding member of the American European Congress of Ophthalmic Surgeons, or ACOS, and he has written quite a number of medical textbook chapters on ICL surgery. His wife, Heather, interestingly, has ICLs in her eyes, and it's neat. Heather is one of those great patients that can testify to the effect that the ICLs have had. Now we're going to go ahead and turn the microphone over to Dr. Parkhurst. Greg, you can take it away here, and I will be getting our patient ready in the back. Once again, if you have any questions or any anything that you would like to share with us, please feel free to let us know what your questions are, and we'll be happy to do this. So, Dr. Parkhurst looks very young, as he stated. He is the youngest founding member of ACOS, and despite his outwardly youthful appearance, he's truly wise and very experienced in the field of ICL surgery. So, Dr. Parkhurst, thank you for being here. I appreciate your speaking to our audience throughout the world.
Thanks, Rob, for the kind introduction. I'm really excited to be here from Houston and participating in this really unique event where we get to share this amazing procedure with folks who may have not heard about it before or just want more information about what the ICL is. And this is a procedure that I've come to gain a lot of experience with over the last few years. And it turns out that it's now my favorite surgical procedure to perform, just because I've been able to see how happy the patients are that are able to have access to this technology. So I want to talk to you a little bit about the ICL, and if we can get the clicker to go again. This is what the ICL looks like.
Okay, hey Tom.
And as you can see, it's a very thin material. It's compatible within the eye. And one of the most amazing things that I find when I implant this lens into the eye is how quiet it sits. I've done hundreds of this procedure, and I've not yet had an eye that rejected the material. So it sits quietly in the eye, and it's made out of a material that's very similar to collagen that's within inside of the eye. So the eye does not recognize it as foreign material, and it sits quietly. This is a schematic of some of the anatomy of the front part of the eye. And as some of you may know, we all have a natural lens inside of our eye, which sits right behind the pupil. The lens is basically the size and shape of an M&M candy, and when we're born, the lens is perfectly clear. And what happens with folks that are very nearsighted is that the lens focuses light rays too strongly relative to the length of the eye. And the light rays come into focus in front of the retina. And so we have several options in how to correct those light rays that are focusing too strongly. And those include many things that Dr. Rivera discussed today, including glasses, contact lenses, LASIK eye surgery. And the way that the ICL works is it helps the natural lens to function more properly. So the ICL is designed to fit inside of the eye and help the natural lens work better. And it sits right behind the iris, or the colored part of the eye. It sits there, and it's completely invisible to the outside world. So if you look in the mirror, you can't see it. Your friends can't see your friends can't see the lens at all. The lens comes packaged in a little vial, and as you can see, it looks very similar to what you might think of a contact lens that you're used to taking in and out at night to clean. except this lens is designed to stay in the eye forever, such that it never requires any maintenance or daily service, and you never have to do anything with it. The lens, we'll see here in just a moment, Dr. Rivera is going to show us how the lens is loaded and inserted into the eye. And these are some pictures of how the lens is placed into a small cartridge. Okay, we're out of sound. If you could hold on 1 second, we're going to take a pause.
Say testing.
Testing. Are you able to hear us now? Testing?
Go ahead and continue.
Testing? Are you able to hear us? So as we were seeing, the ICL comes packaged in a small vial. The surgeon then loads it into a small injector cartridge, which is then inserted into the eye through a small opening. Can you click forward?
Yeah, everything's fine.
Okay.
Oh, sorry, let me...
Right. Glad you can hear us again. So the lens is then loaded into a small injector cartridge, as you can see. And this is a video schematic of an animation of how ICL surgery works. So the first step is to dilate the pupil. So you're given eye drops much like you get when you go see the eye doctor to have a complete eye examination. Then a small opening is made in the front window part of the eye called the cornea. This opening allows us to insert the ICL through that small injector cartridge. As you can see, the lens comes very slowly into the front part of the eye, and then microscopic surgical instruments are used to gently tuck the ears of the ICL underneath the iris. Patients can often see an improvement in their vision instantaneously when the ICL is inserted into the eye. Just imagine, putting a contact lens in your eye at night. You can see an almost immediate improvement in the vision. So we've kind of looked at who are the best candidates for ICL surgery. This is a technology that's now available in the United States for folks who are nearsighted. So what nearsighted means is that with your glasses off or your contact lenses out, you can see things pretty well up close to your face, but things in the distance like the chalkboard or street signs when you're driving are very blurry. So this technology is available to correct for nearsightedness, and it's available in a wide range of powers spanning from -3 up to -16 diopters. So it is available even for extreme prescriptions. I mean, think of those people that you know that have glasses that look almost like they're Coke bottles. These folks are not good candidates for LASIK, but in many cases, these are the people that are ideal for ICL surgery. It's also a good procedure for folks that have thin corneas. This is a technology that adds to the eye rather than taking away tissue, so it doesn't matter how much you have to start with. Folks are still candidates for the ICL. One of the things about ICL surgery that's really nice is that it does not add to any dryness of the eyes. And that has been one potential side effect of some laser procedures, especially in the past, is that dryness of the eyes could be an issue maybe for a few weeks following the surgery. But dryness of the eyes is not an issue with ICL surgery. And actually, this is one of the biggest reasons that my wife, Heather, decided to have ICLs instead of a laser-based procedure. This is also a good procedure for folks who have irregularly shaped corneas, even for folks who have large pupils, and some folks who decide to have PRK surgery, which is a similar laser procedure to LASIK, may also be candidates for the Vision ICL. Also, folks that have other medical conditions that may disqualify them from LASIK, such as collagen vascular disease or certain types of rheumatoid arthritis or lupus, may not be candidates for LASIK surgery, but they are candidates for ICL surgery. If you could just click advance for me. Thank you. And then it also might be a good option for folks who have particular excellent quality of vision demands. I mean, think of folks that are into photography, certain military snipers where night vision is of particular concern. These are folks that might be great candidates for the ICL. I've specifically looked at ICLs in some very extreme conditions when I was serving in the military. And one of the things about military service members all over the world is that many times military operations are done at night. And one of the things about any form of refractive surgery is that we hope to have an excellent quality of vision. So we look at things beyond just whether or not you can see 20/20 on the eye chart. We want the quality of vision, contrast, shades of gray, picking out certain colors, looking at the way stars look in a night sky are all very important in terms of looking at quality of vision. We know that refractive surgery is a very popular procedure to have done in military service members all over the world. In fact, there's an international military refractive surgery symposium which takes place every year in San Antonio, Texas. And military surgeons from all over the world come to share their outcomes and their results. And we've had defense forces from Japan and Singapore, the UK, France, and all three branches of service in the United States participate. And what we hear about is that refractive surgery is an extremely popular option for military service members, specifically because there's a job-specific reason for folks in the military to want to get out of glasses and contacts. Imagine being in a foxhole and having your, exposed to a blast and the glasses blown off. You wouldn't have a good way to protect yourself. So having LASIK surgery or PRK or the ICL are all very popular procedures to have done for this population. In the military, laser procedures are the most commonly performed, very much like they are in the civilian sector. But as we've seen, LASIK has certain limitations. Some patients just aren't good candidates for the procedure. And so we've been studying the results of the ICL in soldiers who weren't good candidates for laser-based procedures. And it was a very large population that we served there. It was the largest military base in the world. There's over 42,000 active duty service members there on the base. And the center performs about 4,000 refractive procedures every year. So it's a good place to help a lot of people and also to get a lot of experience with many of these different technologies that can help people minimize their dependence on glasses and contact lenses. We published a paper in a scientific journal looking at the reasons that folks were getting the ICLs, and the most common reason were folks that had irregular corneas, but also corneas that were too thin, or they had dryness of the eyes, or some other reason where laser vision approach may not be the best option for vision correction surgery. And so the first thing that we wanted to do was to look back at our outcomes after our first couple of hundred eyes, and what we found were astounding rates of 20/20. In fact, 96% of the eyes by 3 months after surgery were at least 20/20 without glasses or contact lenses, and 2/3 of them were 20/15. So 20/15 is even better than 20/20 on the eye chart, and some people refer to this as super normal vision. And many of our patients were telling us that this was the best they had ever seen before, even in glasses or contact lenses, and we found that objectively when we looked back at the numbers that we found. So after that first study, we in our center kind of determined that when a person may not be a good candidate for a laser approach, the Vision ICL was proving to be a very safe procedure and also extremely effective. And the vision outcomes that we saw were at least as good as, if not better, than our laser vision approaches. We then set forth to specifically look at night vision performance. One of the things about eye surgery is that there are several different options we've talked about today. So you can have laser approaches, you can have certain types of intraocular lenses that are used at the time of cataract surgery. And some intraocular lenses following cataract surgery, especially some of the older ones, have been shown to have issues at night with contrast sensitivity and halos. Well, we know that this would be a particular problem for folks in the military that are operating at night under these extreme environments, and so we wanted to measure and see would there be any of these similar issues with the ICL, which again, it's a very similar procedure to a cataract type operation where an intraocular lens is implanted into the eye. So we set forth to study it specifically, and we had something called IRB approval, where the hospital oversaw all the research, and it was done according to a formal analysis, and we compared the best LASIK procedure that we had, which was an all-laser approach, to the ICLs. And we used a specific eye chart that had night vision on it, which simulated the vision that it looks like that you see through night vision goggles. And there were 48 eyes that were enrolled into the LASIK arm of the study and 47 into the ICL arm. And we basically compared the night vision before surgery and then after surgery to kind of see who did better. And what we found in the results of the study was actually that both populations did fantastic. In fact, 94% of the eyes were at least 20/20 or better after surgery in the LASIK group, and we saw that 96% were at least 20/20 or better in the ICL group. But remember, the folks who were getting ICLs were eyes that had some reason to get an ICL, you know, something like a thin cornea or a history of dry eye disease, or maybe something irregular about the cornea. So these were eyes that had something irregular beyond just their nearsightedness that were the reason they were enrolled into that part of the study, and yet they still did at least as good, if not a little bit better than the LASIK eyes. And then when we specifically looked at night vision, so I'll have to draw your attention to some of the numbers on this slide. This is the way that we measure visual acuity, specifically down a special kind of an eye chart that helps us look at visual function according to a mathematical logmar scale. And every letter on the eye chart, the smaller you get, the patient gets a score of minus 0.02. So in this case, it's better to be more negative, kind of like a golf score. So what we saw here was that the ICL patients had a significant improvement in their night vision after ICL surgery than they had ever seen before. And what we then found objectively is what our patients had been telling us. They'd come in and say, "Doc, this is the best vision I've ever had." And we'd say, "Okay, well, you know, that's kind of neat. You know, usually when we do refractive surgery, we can become about equal to what you've seen in glasses or contact lenses, but usually the goal is not to see even better." But the patients were telling us, "No, Doc, I'm telling you, this is the best I've ever seen." And then we were able to measure that objectively with one way of looking at quality vision, specifically night vision. And again, you can see on this slide what we found was that the LASIK patients actually had a trend towards improvement in their night vision as well. It didn't turn out to be statistically significant like it was with the ICL group, but both forms of these refractive surgical procedures resulted in objectively better quality of vision than folks had ever seen in the past. We also looked at contrast sensitivity under a night vision filter. You know, again, it's kind of like the vision through night vision goggles that folks will see, and we saw a better improvement in contrast sensitivity in night vision with ICLs than we did with LASIK. So in conclusion with the ICLs, what we've seen is that clinically we've found the results to be excellent. Subjectively, the patients are extremely happy. They've told us about the quality of vision that they get being extremely good. And we've also been able to measure that specifically, not only on the 20/20 scale, but how people see at night under a night vision performance with contrast sensitivity. And so we find that many of the advantages of this procedure include, you know, excellent quality of vision, and then there's less concern about, you know, some folks who may not be good candidates for other procedures. You know, we don't have to worry about dry eye. This is a reversible procedure or a removable procedure, which is really nice. You know, one of the things about LASIK is that it's a permanent thing. So, you know, it's extremely uncommon for someone to have some type of side effect that they don't like about their LASIK procedure. But if that happens, you know, 1 out of 10,000 times, there's really no going back. Whereas with the ICL, if there was some strange thing or side effect the person didn't like about it, they do have the option to have this removed, which is really nice. To date, I've never had anyone ask me to remove one, but it is nice for those patients to have that kind of trump card in their back pocket. It makes them feel that they have control. If there's something they're not happy about, they could always go back to their glasses or contacts like they used to have. So what we've seen is that ICL now continues to grow globally. We have a huge audience of listeners tonight and from all over the world, and what we've seen is that this procedure is being used more and more. Back in 2008, statistically, an ICL was implanted about every 20 minutes around the world. By 2009, that had grown to an ICL being implanted every 12 minutes, and today, in 2012, it's interesting to note that every 6 minutes, an ICL is implanted. We're about to see 2 be implanted in front of our eyes, and I've been talking now for, what, maybe 10, 15 minutes. There's probably been several ICLs implanted somewhere around the world as we've been going. One of the other things that some of our patients who come in desiring vision correction surgery may have been told in the past is that, you know what, you're too old for LASIK. You know, you should probably wait a while, and maybe someday, you know, when you get a cataract, you might be a good candidate for a surgical procedure. So in the old days, we'd tell people to wait. But one of the things that has happened over the last few years is that the technology advances in our field have been have been huge. You know, only 20 or 30 years ago, if someone were to have a cataract operation, they might be laid up in the hospital for about a week, holding perfectly still in the hospital bed with sandbags around their head so that they didn't move and nothing went wrong with the surgery. Nowadays, we're able to do cataract surgery through a small opening in the eye about 2 millimeters long. We're able to replace the cloudy cataract lens with a synthetic lens implant. And so many of the complications that were potential there in the past just don't exist anymore because of advances in the technology. We're now able to do all laser cataract procedures. And so for some folks who've been told they're maybe a little bit past the ideal age for LASIK, should wait for cataract surgery, may not have to wait anymore. The technology has gotten to the point where folks who want to have the intraocular lens inside of their eye replaced could have a synthetic lens implant, much like the ICL, and get the benefits of vision correction surgery without having to wait. This is one of the most popular procedures in my practice now because we now have intraocular lens implants for folks that can see not only far away, but even up close in the same eye. This is basically like having a bifocal intraocular lens implant put in the eye. So for folks who've been used to wearing glasses when they were younger all the time for distance, then when they became usually age 40 to 45, needed a bifocal to help see, you know, far and up close, can now have a procedure inside of their eye to help see both far away and up close in the same eye. So this specific procedure that we're referring to is called the laser refractive lens exchange. And we now have technology both here at Hoopes Vision. The folks have them here. We have them in our practice in Houston, where we can do the entire procedure with the use of a laser to soften the lens and remove it, and then replace the cloudy lens or dysfunctional lens with a synthetic lens implant. So the laser refractive lens exchange procedure affords excellent quality of vision. An artificial lens can be implanted. There's no daily maintenance that's needed like contact lenses that you might think of that are taken out nightly. And just like the ICL procedure, which we're going to see here in just a couple of minutes, this procedure is also exchangeable. If anything were to change down the line, you would have the option to have it removed and reimplanted. The laser refractive lens surgery procedure is comfortable. It's very much like LASIK for many folks who've had friends or family members who've undergone a LASIK surgery. Understand that this is outpatient surgery. In fact, we're almost getting to the point where folks could go back to daily activities even sooner than 24 hours. I would predict that within the next 5 or 10 years, we may be able to offer something like lunchtime LASIK. Come by and get your LASIK procedure over your lunch break and go back to the office in the middle afternoon. So this is kind of just describes the quick recovery that people have, the comfort of the procedure, and very limited limitations. You can basically go back to normal activities very quickly. And so we're able to offer this same type of laser procedure for folks that are having both cataract surgery and the laser refractive lens exchange procedure. So this might be a good option for folks that are getting toward the age of 45 or 50 where they're noticing that things, especially up close to their face, aren't clear in focus anymore. Many of my patients report that the thing they notice most commonly is that they have to hold their arm out a little bit farther and farther away, whether it be the menu at the restaurant or the novel that they read. They have to hold things further away from their face for things to come into focus. Now we have intraocular lens implants that are designed to give both far and near vision, and this might be an excellent option for folks in that age range. It's particularly ideal for folks that have really high prescriptions, especially far-sighted prescriptions, or if they have early cataract formation. So in conclusion, vision correction surgery can come in many different forms. We have excellent outcomes that we see when performed by the best of hands by those surgeons here at Hoopes Vision, and also very pleased to work with a world-class surgical facility in Houston with Dr. Stephen Slade and Rick Baker. So when performed by the best of hands upon the best of patients that are chosen carefully, and the best procedure is selected for each individual patient, we can truly have excellent outcomes for a whole host of patients, a whole host of ranges with a whole host of different refraction problems with their eyes. Each type of surgery has its own benefits and its own advantages, and so I'd encourage you to talk to one of the doctors here at Hoopes or or certainly come to us in Houston, and we'd love to talk to you more about some of the surgical options that we have nowadays to correct your vision error. So basically the take-home point for us now is that in 2012 and going into 13 and beyond, you don't have to remain limited by poor vision. You don't have to remain limited by the inconveniences of glasses and contact lenses. Glasses that, if you're a military service member, might be at risk of getting blown off during a blast overseas, or if you're a cyclist that doesn't want to have to worry about the sweat getting in the glasses. Or a whole host of reasons. You don't have to wait anymore. There's now a solution for even the most challenging situations, whether it be the ICL or other lens-based approaches, or possibly with a laser-type technology. The most common statement that we hear from our patients is, "Why didn't I think about doing this sooner?" So don't wait. I'd encourage you to come in for a consultation, and we'd be happy to take a look at your eyes and discuss all of the options that you have, from laser-based approaches to ICL surgeries and other types of lens implants. So let's see where we are back there in the OR. And all right, y'all want to go ahead and get started back in the OR? I think the patient's just about ready.
Okay, it's Dr. Rivera. This is our operating room here at Hoopes Vision, and you will be able to see our live ICL surgery as we proceed throughout the evening's procedure here, throughout the evening's case. Now, I am currently dressed in my sterile gown and gloves. You might have heard the sink previously. I think that drowned out some of the noise there where I was washing up, so I apologize for that. We dealt with that by muting my mic temporarily. We are now back live, and we have a little bit of an introduction to our patient here, Ian, who is a 29-year-old, fairly high myope. We're implanting -8 implantable contact lenses in each eye. -8 is a very, very strong prescription, and so we'll turn this over now and show a little video segment that we took of Ian just prior to his being here. Let's see, are we ready with the video?
Hi, my name is Ian Fife. I'm here at Hoopes Vision, about to undergo a new procedure, well, a newer procedure called ICL. I had entered into the Hoopes Vision video contest to win free LASIK, and although I didn't qualify for LASIK, I was hoping to maybe do PRK or something else, and they came to me and offered this opportunity to do this ICL procedure, which I'm really excited about. Be able to get rid of my glasses and contacts finally. I've got terrible vision. Ever since I was in 6th grade, I've always had to wear glasses. Right now my vision is about a -6.5 and -7 in my eyes, and so I definitely need to wear some sort of a corrective lens in order to see good. And so real excited to be here, a little bit nervous, but grateful for this opportunity.
In just a few minutes, in this exact same room, right where you're standing, that's where you're going to be having the surgery. And at the end of the surgery, Dr. Rivera is going to have you look across the room through the clock that's on the wall. Be able to see that clock?
Yes.
Okay. One of you, if you would just take off your glasses and let us see how close to that clock you have to get in order to see it clearly.
Okay. Right about here.
Okay. We'll have you come back in just a few minutes for surgery, and we'll see how you do after the surgery.
Great, thank you.
Thank you.
Okay, so I think you got a pretty good idea of how nearsighted Ian is. By the way, if you have any questions that you want to ask live via Twitter, you can go to @HoopesVision, that's HOOPES Vision, #live-surgery, and we'll be happy to answer your questions live. So we'll go ahead and get started. I believe we are ready. Ian is a very comfortable and cooperative patient here, so we'll get things taken care of. We're going to start with the right eye. If you could switch that to be in front, please. Thank you. Okay, now we have a nice operating microscope. Ian, can you hear me? Okay, great. Now here comes a very bright light. This is from the microscope. And people are going to be able to watch your eye here on our screen and on their computer monitors throughout the planet. Isn't that amazing? Now I have a foot pedal that I can control my zoom and some of my movements of the microscope here, so I'm just positioning that, making sure that it's totally comfortable. A little bit more irrigation, please. Now Ian is also a contact lens wearer, so you'll see that he does have some fairly prominent blood vessels. Ian, can you look right at the light? It's fairly uncomfortable when we start at first. I'm going to position this a little bit better. This little device holds the eyelids out of just out of the way so that we don't have to worry about the patient blinking during the surgery. This bottom one needs to be just a little better. There we go. Okay, now can you look way down towards your chin, Ian? Way down. Perfect. Beautiful. Now that light gets much more comfortable for you as we go along here. And I want you to try and look straight at it for just a second. Look down towards the light a little bit. This helps stabilize the eye also, and keep looking right straight ahead there. That is perfect. Excellent. So we make a tiny little opening there. And look just a little bit down for me. Now here's where the blood vessels are from contact lens wear. So he's likely to have perhaps not even a drop of what you might see on the screen there as blood, but it's really not much at all. There's my other little entry where we're going to create a little iris opening. Now, Ian, are you feeling okay? Is that light getting more comfortable?
A little bit.
Okay. Now, right now, I'm going to place a little bit of numbing medication right there. You might feel just a little bit of extra pressure, sometimes not at all, but that's some medication to help the eye be nice and comfortable, just to take any extra discomfort away if you might have any of that. Now for the next step, I'm going to place this very viscous substance into the front part of the eye. You might see, look straight at the light for me, please. Look right straight at it. Look down at it a little bit. Perfect, excellent. So you might see those little ribbons there on the camera, and if I can ask my OR staff to help me make sure that I'm centered on the screen so that you can see as close to what it is I'm viewing here. But this is a cushioning gel. It's known as a viscoelastic. And it just applies some cushioning there so that we can safely implant the ICL without any rubbing against the internal structures or anything like that at all. Very comfortable procedure to have done. Now sometimes, Ian, the vision does get dark while we're doing this part of the procedure. Okay, so now we've prepared the internal part of the eye to receive the ICL. And Ian, I want you to look down just a little bit for me. That's perfect. Now we're going to stabilize the eye here. And this is actually a diamond bladed scalpel that is only 2.9 millimeters. That's all that is. And that goes right in there. That's all we're going to need to implant the lens. And as you'll see here in just a moment, the lens has already been folded and loaded into this tiny little injector here. The tip of my injector is right at the opening that I've just created. And we're very gently going to just pulse the lens into the eye and allow it to unfold as it goes in. The most important part here is to make sure that the lens unfolds correctly. And we're just going to let it open up a little bit there. Beautiful, very nice. And the lens is now inside the eye, Ian, so you are now wearing an implantable contact lens in the right eye. Now what we're going to do for the next step is very carefully position it where it's going to be. It'll be in the space just behind the iris. And there's a little foot plate right there, which is called a haptic. That just gets tucked in right to the back. There's another one right there. And then we're going to take care of these that are closest to me in exactly the same fashion. Ian, you're doing absolutely wonderfully here. It's coming along just beautifully. One last little haptic to position. Keep looking straight ahead for me, please. And there we have the ICL positioned. It looks absolutely beautiful. It looks perfect. Now, there's a couple of different things that we can do here, because one of the things that we know is that statistically patients who are higher nearsighted especially might have a higher risk of developing a high pressure inside the eye. So patients can actually have a procedure known as a laser peripheral iridotomy done ahead of the ICL implantation. And in that case, what we do is make a tiny little opening in the colored part of the eye with the laser. And Ian, look a little bit down for me, please. A little bit more. More centered, thank you. Is that better there? So right now what I'm doing is applying a medication that's going to cause the pupil to start constricting and coming back to a more normal size. We've really dilated his pupil. We wanted to get it as dilated as possible to be able to implant the ICL. But now we want the pupil to constrict, because rather than go through the laser iridotomy, we're going to create the tiny little iris openings surgically. Now look straight at the light for me and look down just a little bit. Perfect. That is excellent. Keep looking down just a little bit. Yes, we have a question. The type of scope that I'm sorry, by user tumbleweeds? Wonderful. I love that, that name, by the way. That reminds me of my home in New Mexico, where we had plenty of them. This scope is actually a Leica. It is of Swiss and German manufacturer, and it is absolutely just a beautiful, beautiful view that we get here. I hope you're getting a good view through the internet, because it really is quite remarkable. So now we've let the pupil constrict, and Ian, what I want you to do is look straight at the light for me. Perfect, and then a little bit down from that. Perfect, excellent. Excellent, very nice. So I'm just going to make sure that the iris is away from this little corner right here, because I'm going to use that opening to create the little iridectomy. This is a surgical iridectomy. And keep looking down for me just a little bit. That is. Keep looking down just a little bit. Keep looking down. Keep looking down. Perfect. Keep looking down for me, please. Down. Keep looking down. Okay, and just keep looking way down. That's a good spot to look at right there. That's perfect. Excellent. Keep looking down and try and keep your chin up for me, please. Now keep looking down. Excellent. Keep looking right there. Yeah, try and hold nice and still from here. And keep looking down again. So that's perfect. That's just a tiny, tiny little bit of iris that we remove there. And then look straight at the light. Toward the him. Look down just a little bit from there. Okay, hold that very steady. We're going to see that little opening here in just a second. Now bring your chin way up high. That's good. Hold your chin right there and then look down. Okay, perfect. Very good. And now I'm just going to make sure that from the internal aspect, that little opening is all the way through, and look a little bit down from there. Now try and keep looking right at that same little spot. That's excellent. You're doing great. It is just coming along beautifully. And look down again. Perfect. Keep looking right at that same little spot. Keep looking down. Excellent. You're doing great. Okay. So now we've made sure that that opening is in fact all the way through. And we're going to apply just a little bit of some irrigation through here. That'll help get all of that cushioning gel outside of the eye. And you see there's a couple of little bubbles right in through there. Those bubbles are going to gradually dissipate and they'll be gone. Now look a little bit down from there. Perfect, excellent. Okay, very nice. Now we're just going to test, make sure that the eye is nice and inflated. Now Ian, you have absolutely done beautifully. The right eye is all done. So that was excellent. Once again, if you have any questions, at Hoopes Vision, Hoopes with 2 O's, #live surgery. Okay, Ian, wonderful. How are you feeling? Okay. Pretty bright light there, isn't it? Mm-hmm. That's great. Well, the right eye's all done. You've done just absolutely perfectly. That went very smoothly. And what we're going to do now is get the room ready for his other eye. Now, since this is surgery that's considered intraocular, and we do go inside the eye itself with our special instruments, for the other eye, we make sure that we use a totally different set of instruments that comes from a different sterilizer. We use all different lot numbers of solutions, eye drops, lens implants. Everything that we use in the operating room is totally different. So in this way, it's as though he had come a month later for his second eye. And we're able to take care of both eyes like this. We've called this procedure short interval bilateral surgery, or SIBS, interestingly enough. And it works very well for patients having this type of intraocular surgery, where it really separates the case into 2 different procedures altogether, as opposed to having everything just done with the same set of instruments in both eyes. So we'll certainly appreciate your continued interest here. You've seen one eye done. We're going to follow up with the left eye now. And as soon as we're done with his left eye, we're going to ask him to read the clock again on the wall. I think you'll be amazed to see how quickly the vision comes back. And I'm going to take just a moment here. If there's any questions, we'll be happy to answer any of these for you. Is there any pain involved? Let's go ahead and ask our patient. Ian, can you hear me?
Yeah.
Did you have any pain?
Minimal.
Minimal? Little pressure, foreign body sensation, or what exactly did you feel?
Yeah, mainly pressure and just...
A little bit of pressure?
Yeah, foreign body sensation, like you said, just some different, preoccupying that I've never dealt with, obviously, before in my eye. Mm-hmm.
Now, it wasn't enough to want to kick your surgeon?
No.
Excellent. That's the answer I was looking for. Thank you. Of course, we have an anesthetist here that helps keep him comfortable as well. So, thanks for the question. Babette is asking the question: how long is the recovery time following ICL surgery? It's really quite minimal. It's the same as LASIK. We ask our patients not to do any strenuous activity for about a week. No heavy lifting where you have to strain to pick something up. No soapy water in the eye. You know, if you're a downhill skier, we want you to stay away from that probably for a week or 2. If you're a water skier, we don't want any high impact water sports for probably about 3 months. And that is the same as we instruct our patients with LASIK. The ICL is actually very stable once it's inside the eye. It's a very difficult lens to dislodge or dislocate? That's another question that's often asked, and we've seen an occasional, a very rare patient here and there who has been involved in some serious motor vehicle accident trauma where the lens has come dislodged, but it's very easy to replace. There was a case report of an American soldier in the Middle East who had a grenade go off and exploded approximately 5 feet away from him. He had had ICL surgery in the months preceding his deployment, and he absorbed the full impact of the grenade blast with a subsequent trauma. Thank the good Lord he was able to survive. He survived his injuries. He did have some hemorrhaging inside the eye from the concussive force. Nothing had penetrated the eye, but interestingly his ICLs remained very stable and did not need any attention whatsoever. So we do see that the lens implants are very stable once inside the eye. Another question that's often asked, if I might just add to the discussion here, is it possible to remove the lenses later? And the answer is yes. If the patient's prescription changes quite a bit and their vision, their prescription has become stronger, for example, the lens implant can be exchanged at a later date for a new prescription contact lens. In my experience of close to 3,000 of these surgeries, I've only had to do that once, so it's very, very unusual that this would be the case. More questions? Excellent. How much does the ICL procedure cost? The ICL typically costs around $1,000 or so more than LASIK per eye, because we do have a lens implant that you basically take with you. So if LASIK, for example, in our center here is approximately $2,200 per eye, $2,300 per eye, you would add $1,000 per eye for the cost of ICL. There is a lot of interest in ICL surgery nowadays, and internationally, for example, you might see that patients as much as 30% of the time are selecting ICL for their vision correction surgery. ICL is growing worldwide. There have been over 330,000 ICLs implanted worldwide. I believe the statistic is approximately 1 ICL every 7 minutes, if I'm not mistaken, is implanted across the world. The procedure is growing in some areas of the world by 35% year over year. So it truly is just an amazing vision correction surgery that patients can have a lot of benefit from. The question is, is there any treatment that can be done to stop deterioration of prescription? And typically, that's something that we feel is dictated by your genes. So if your genes are telling your eyes that they need to become more nearsighted over time, they will do so. The good news is that typically doesn't continue throughout your whole life, and there is a point there at which they do become stable. If we're to do any type of vision correction surgery, of course, we want you to have a stable prescription and not be worsening from year to year. But as I say, with ICL surgery, it's very unusual to have to exchange them purely for the basis of prescription. Do I need to get out of the way here? Am I okay? We're going to go ahead and commence with our preparation of our patient for the left eye surgery. If you have any other questions, please keep them coming. We're delighted that we have our online audience. And I need to have my phone taken off, please. So we're delighted to be able to answer these questions from everywhere across the globe. Now you can join us on our Facebook page. We have a Hoopes Vision Facebook page. Also, we have a Google Plus page at which you can join and follow us as well. Please feel free to post on our website, on our Facebook page. If you have any email questions or anything like this, we're very, very good about answering any of these questions for you. This is your chance. This is your chance to ask any type of question you might have. Twitter, of course, is @HoopesVision, #LiveSurgery. So feel free to keep these questions coming. And there is no such thing as an unfair question. So please ask. Question, is this the same as cataract surgery? The answer is no, it's not. With cataract surgery, we actually remove the lens inside the eye. and that lens is liquefied and literally removed, and in place of your natural lens, we implant a new lens similar to what I just did with the ICL. The difference here is that we're leaving the patient's natural lens untouched, and the ICL simply goes on top of it to add the prescription power to that lens. So very different surgery. This is far less invasive than cataract surgery. I hope you're all enjoying the event tonight. It takes quite a bit of preparation for this, and we want to express our appreciation to all of our great OR staff here, our IT folks as well. Takes a little bit of logistical shuffling to pull something like this off, and I truly hope this is an enjoyable event for you. We are setting history, by the way, and taking these live surgeries to the internet. This is something that's actually garnered the interest of a number of news outlets across the country because, number one, it's live. There's no better way to watch surgery than live. You can't catch that on cable television. Everything you watch on cable TV is edited. This is completely unedited and live. The other thing is there's no limit to where this can go unless X, Y, or Z country might not have internet access. So we've had viewers to these type of events previously from Great Britain, from Chile and South America, from Asia and so forth. So we're truly delighted to be able to do this type of event for our online audience. I will need to actually scrub up. I'll put some disinfectant on my hands. Our patient is being draped at the moment, so I'll go ahead and get that done. Great. Tom, can you mute my microphone? Can you mute my phone? Can you mute?
I have a question, Dr. Parkhurst. The question is, how long has the ICL been around?
So the question is, how long has the ICL been around? The ICL was invented by the Russian Dr. Fyodorov back in the early 90s. And there have been several advancements in design since that time. It was approved for widespread use in the United States in 2005. So it's been used for a lot longer internationally than it has in the United States. And again, there's been over 300,000 lens implants now. I've been using the ICL since its approval, several years ago, and it's just been awesome. I had a chance to do hundreds of them in my practice to date, and so much I liked them so much that we opted for that for my wife.
Tom, yeah, we're ready. Go ahead and tell Tom to turn the mute back off. Good. You are unmuted.
Okay, welcome back. We've got our patient draped and ready for the procedure on the left eye now, so we'll go right ahead and get that taken care of. We've made sure that everything is from our separate lot numbers, and we'll be able to thereby ensure that nothing that has touched the right eye touches or comes into contact with the left eye. Okay, Ian, here comes that bright light once again. Bright light from the microscope there. Very, very bright as we first start. Okay, now Ian, can you bring your chin up towards the ceiling? Perfect. And he has had drops topically? Great. Ian, I want you to look down towards your chin for me, please. Very nice. Keep your chin up for me. Chin up. Perfect. So we're going to make one tiny little opening right here. then look down just a little bit for me, Ian, a little bit more. Down a little bit more. Down a little more. That's perfect. Excellent. Hold that steady as you can for me. That's great. Wonderful. Then a little bit farther down. Beautiful. Excellent. You're doing great. Now at this point, I'm going to place some of our numbing medication right inside there. You might feel a tiny bit of pressure with this. If you feel pressure, that just means the medication is going to work, and it makes the eye nice and comfortable for us. Now bring your chin up for me, please. That's great. Apparently we do have some viewers in Brazil. So, brasileiros, bienvenidos. That's the best I can do in my Spanish, and I have no idea how to say that in Portuguese. Okay, now this is some of that cushioning gel. You're going to see a bunch of wavy lines in your vision here. That is excellent. Looks good. Now, Joe, if you see that I need to be centered or anything like that, please let me know so we can make sure our viewers are watching. Comedy Speakeasy on Twitter wants to know how they can tell this is really live. Is that good enough? That was 3 minutes ago, apparently. Now look right straight at the light for me. Has the light gone dark for you here, Ian?
Yeah.
Okay, good. So look down just a little bit. Perfect. And now we're going to make our incision right here. That's to accommodate the ICL as it goes inside the eye. Ian, you're doing beautifully. It looks absolutely perfect. Now just keep looking right there. That is excellent. Now look a little bit down for me and bring your chin up. Perfect. Then down. Excellent. Very good. Okay. So now we're going to place our little folded ICL that's prepared in this tiny little injector right at the opening. You're going to very carefully pulse that in. A few little bubbles going with that, which are not of any concern. You can see the bubbles come right out. One interesting story, we did a seminar live just like this previously, and we had the same question: how can we tell this is live? And so the viewer asked that I say, hello Sparta, whatever that might mean, and so we had a little bit of fun with that. Now look just a little bit down for me, please. We're now going to position the ICL right in its position behind the iris right there, with the other foot plate or haptic right there. Then we're going to do exactly the same thing with these two other haptics here. Ian, you're doing beautifully. Just keep looking straight ahead for me there. Look down just a little bit. And right there. Great. So now the ICL is in its desired position. Dr. Hoopes Jr. Yeah. Say that again. Bem-vindo. Bem-vindo. Dr. Hoopes Jr. just told me how to say welcome in Portuguese. Bem-vindo. And now bring your chin up for me. Look straight at the light.
So we're back on.
And just
So we're back on now live. We were having some technical difficulties with the video equipment, but the surgery is still ongoing, and you should be able to see the rest of the procedure here any moment. Go ahead and send us any questions that you might have through Twitter or online at the Facebook page. We'd be happy to answer any questions that you might have live.
Procedure here. Now bring your chin up for me and look a little bit down. There you go. That's perfect. Hold that nice and steady. Excellent. Keep looking right about that same spot. And this is just to make sure that we are in fact through the opening itself. And look just a little bit down. What I want to see is a little bit of the iris pigment in the fluid that I squirt out, and I was able to see just a quick little view there that is in fact open, so this is good. And now look straight ahead for me and bring your chin up. Perfect. Okay. Ian, you are almost done. You were just doing wonderfully here. Now we're going to irrigate and remove that viscoelastic material from inside the eye. And once again, I really want to express our appreciation to all of you who have taken time to be here with us this evening. We're also especially grateful to Google Hangout for making this event possible through their wonder of the internet and their particular URLs that make it easy for us to come online and do this. So we're very much in awe of this technology and want to express our gratitude. Now we do have a couple of questions. So the question is, as a child, this person could see far and near, but now near only and not far. The ICL only corrects, in the United States, the version of the ICL that we have only corrects nearsightedness, but not presbyopia. So once you reach the magical age of 45, besides the fact that gravity works on you, your eyes no longer can focus for near, and that's the point at which patients will typically go into reading glasses. Now, Ian, we are all done. Congratulations. You did beautifully. How are you feeling? Good. Feeling good. Now we're going to take everything off of you here. Ian, the right eye is probably going to have a little bit better vision in it since it was done first. We've just barely taken that bright light away from the left eye, so it may still be a little bit kind of washed out vision-wise, kind of like when you stare at a bright light for a while. How are you feeling? Good. Good. Can you see us there, Tom? Okay. Well, right behind me here, I have the clock that you looked at and tried to read very close early. Are you ready to take a look and see if you can see the time?
Sure.
Okay. So let's see. It's right over here to your left. Can you see it on the wall?
7:19.
7:19. That is wonderful. Congratulations. That's the moment that changed your life, I think. Now with your ICLs, you are going to be seeing typically better than ever before. We do have quite a number of ICL patients who feel that their vision is better with ICLs than it ever was, even with their best pair of glasses and contact lenses. So that begins the conclusion of our online program. We appreciate that you have all been here to watch this. Absolute history in the making. You know, to be able to do this live, not recorded. By the way, these events are being recorded and you'll be able to watch them later. But as far as tonight is concerned, you have been here to witness ICL surgery as I have seen it through a microscope. And I hope it's been an educational and certainly an informative event for you. It's been wonderful to have you all here. We do have some more questions. So Joe, please. Can the surgery be performed for people with high astigmatism? Depends on what you mean by high. There are types of ICLs that actually correct for astigmatism also. They're currently under FDA review in the US. They are available in quite a number of countries outside the United States, and we're really hoping that the FDA approves these for implantation in our U.S. citizens. In my previous practice in Arizona, we were also one of the clinical study sites for the FDA for that lens. It's called the Toric ICL, Toric, T-O-R-I-C, and truly, truly amazing results. We can, in that case, correct astigmatism that is in pretty high levels of up to about a 4 to 6 diopter range. Now, interestingly, if you have higher amounts of astigmatism than that, if you have the right kind of corneal tissue, we can also combine a toric ICL with other astigmatism correcting techniques to take care of the entire amount of astigmatism you might have. So there's quite a number of ways we can customize this that really bring us to the absolute forefront of correcting even higher levels of astigmatism. Is there an age where you can't have this done? In the U.S., the approved age is 21 to 45 years of age. Our patient here is 29 years old. Now, patients younger than 21 have been done, including a handful of pediatric patients. For various reasons, they had to have surgery in order to preserve their vision, keep their eyes from becoming lazy as they would grow. Now, on the upper end, patients older than 45 can also have this done. I've operated on patients well into their 50s with ICL surgery. We do know that everybody eventually develops a cataract, however, and if you've had an ICL implant done and you develop a cataract when you're 50 or 60 or 80 years of age, the fact that you've had the ICL doesn't make it any more difficult to have that cataract surgery whereby your natural lens has become clouded. We remove the ICL implant, then we remove your clouded cataractus lens, and then we replace everything with a new lens implant which actually has your ICL prescription in it also, and that way you don't lose any vision at all. So typically, like I say, 21 to 45, although we can make exceptions to the rule on both ends of the spectrum. So the last question, is the patient completely awake and alert? I think our patient here, Ian, received a little bit of IV sedative, not enough to do anything more than just keep them, really comfortable during the procedure. Patients can have the procedure done without any sedative at all. I've done quite a number of patients that have had that. I myself have had LASIK in both eyes and a corneal inlay in my left eye to help with my reading ability. And in that case, in my own case, I didn't use any sedative whatsoever. But we're certainly able to keep our patients very, very comfortable with IV sedation during the procedure. Some clinics use oral pills, Valium, for example, just something to take a little bit of the edge off and make it a more comfortable experience. Ian, how are you feeling?
Good.
Feeling good? Anything you'd like to say to our online worldwide audience here?
No.
There's our camera over there. Can you see the camera?
Yes, I can.
Can you see what kind of camera that is?
Well, I see a Sony strap.
Okay, so it's a Sony. All right, that's good. That's great. Ian, congratulations. You did beautifully. We appreciate that. Once again, thank you, everybody, for your help. Wonderful staff we have here helping us make this online experience possible for everybody throughout the world. Watch for more of this. You can go to our website, hoopesvision.com, and we will be presenting more of these online seminars in the future as well. Thank you. I appreciate your being here with us, and I hope it truly has been informative and educational, and we'll be closing up now. Thanks very much.